Well, good afternoon, everyone, and welcome to the September 5th meeting of the um, Emergency Medical Services for Children Advisory Committee to the New York State Department of Health. My name is Art Cooper. I have the honor of serving as your chair at your request. Before we get down to business, we do have some new faces, so why don't we just very briefly go around the table and let people know who we are, where we're from, and what we do. Very briefly. Thank you.
Middle. Oh, thank you. I'm Kevin Albert. I'm a primary care pediatrician, and I am from directly across the street.
Afternoon, everyone. Joe Pataki. I'm a chief with the New York City Fire Department's Bureau of EMS. I previously worked at the EMS Academy. I'm currently assigned to Brooklyn and Staten Island, and I offer the perspective as the EMS provider, being a paramedic for the last 25 years.
Hi, everyone. Good afternoon. My name is Vince Caleo. I am a pediatric emergency medicine provider from SUNY Upstate, and I'm also a toxicologist, so I do the medical direction for the Upstate New York Poison Center.
Hi. Hi, I'm Kim Wallenstein. I am a pediatric surgeon. I'm the pediatric trauma medical director at SUNY Upstate in Syracuse, and I'm also the chair of the pediatric subcommittee at STAC.
I'm Sharon Chimento. I'm a registered nurse as well as a paramedic and an EMS instructor at Monroe Community College.
Hi, I'm Nicole Toole, Director of Operations at Irway Ambulance and also a parent of a previously injured child.
Jacob DeMay, Pediatric EMS Data Specialist with the Bureau.
Hi, I'm Amy Eisenhower. I'm the EMS for Children Program Manager for the State of New York.
I'm Art Cooper. I'm a pediatric surgeon from Harlem Hospital. I've been there forever, and again, have the honor of chairing the committee at your request.
I'm Ryan Greenberg. I'm the director of the Bureau of EMS and Trauma Systems. I have not been here forever, especially compared to Art and his many hats that he wears. Just happy to be here in person. Nice to see people face in person again.
I'm Elias Vanderjacht. I'm a pediatric critical care physician at the Golisano Children's Hospital at the University of Rochester Medical Center, and I'm vice chair of the committee.
Hi, good afternoon. I'm Matthew Harris. I'm a Peds EM and EMS physician at Northwell Health. I think this is my first in-person meeting as like a fully vetted member. I've been sort of pretending for 2 years. Just honored to be here in person.
Hi, Ben Casper, a paramedic and injury prevention and outreach specialist over at Oshai Children's Hospital, standalone level 1 Ped Center.
I'm Mike McAvoy, and I'm the chair of the State EMS Council, and I guess I have something to do with children. I'm a nurse clinician in adult and pediatric cardiac surgery down the street here at Albany Med.
Jason Haig, paramedic and EMS educator from Wayne County, New York, here with the perspective of an EMS provider.
Doug Hexel, I'm an EMS provider as well, and EMS educator. Make my living as a fire officer over in Schenectady, not too far from here, and also my first meeting here as a fully vetted member.
Good afternoon. My name's Ed Conway. I'm Chief of Peds Critical Care and Chairman of the Department of Pediatrics at Jacobi Medical Center in the Bronx.
Hello, I'm Dr. Pamela Foyer. I'm the Director of Peds Critical Care at Northwell Health, Staten Island University North.
Well, thank you, everyone. We haven't had quite so well-attended a meeting in quite some time, and this is great. For me, it's a personal pleasure to see the enthusiasm, that you're all bringing, to the care of children, remember that emergency medical services for children, as defined in federal law, as well as in our state charter, and encompasses the entire spectrum of children who require emergency care, starting with, the access, prevention, access through pre-hospital care, acute care in the emergency department, critical care in the ICU, and in the inpatient units after a step down, and of course the operating room when necessary, and of course finally rehabilitation. So our role is to touch on many, many things. Historically, our key foci have really been, on pre-hospital care and emergency department care, but our mandate extends much more broadly than that. And so I just want to remind everyone that that's where we are and that's what we do. And at this point, Amy, are we okay attendance-wise, quorum-wise?
So, yeah, we just need to call the meeting to order and then take.
Oh, I thought we did. I thought we did call the meeting to order. Okay, well, we'll officially call the meeting to order now then, and Amy will take attendance. Thank you.
Are we on the record? Awesome. Dr. Arthur Cooper.
Here.
Dr. Vanderjack.
Present.
Dr. Albert.
Present.
Bruce Berry is absent. He sent me notice earlier. Sharon Chiamento.
Present.
Dr. Conway.
Present.
Dr. Pamela Foyer.
Present.
Dr. Kaleo.
Present.
Doug Hexel.
Present.
Nicole O'Toole.
Present.
Dr. Bombard is absent. She gave me notice earlier. Dr. Harris.
Present.
Chief Pataki.
Present.
Jason Haig.
Present.
And Ben Casper.
Present.
We have quorum.
Thank you so much. It's become our custom here at our state EMS meetings over the past few years to all stand and recite the Pledge of Allegiance together, so we will do that now. Thank you. Okay. And the flag is over there. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Okay, so Mr. Greenberg and Ms. Eisenhower have asked to switch their order of presentation today, so we're going to hear first from. Oh, sorry. I didn't see that in the agenda. So we will first oh yes, it's right there, sorry. Has everyone had an opportunity to review the minutes? They're inboardable.
Motion to approve.
Is there a
Sharon
Second.
Chimento.
Sharon and Elise, thank you. Any additions, deletions, corrections? Okay, hearing none, please signify by saying aye if you approve.
Aye.
Opposed? Thank you. Okay, carries without dissent. Okay. Okay, Amy, take it away.
Amy Eisenhower. So we've had some things in the EMS for Children grant program going on the past few months. As I announced at the last meeting, April 1st, we received continued funding with the new grant period that will last the next 4 years. So we're very excited for that and thankful. So over the summer, we had to revise some budgets because not a lot of the funding came through as much as they expected, so we just revised some budgets and sent all of that back. On August 1st, they released the performance measure manual, and I will have a detailed presentation on that at the next meeting because the manual and the guidance related to that from HRSA came out after all these documents had to be in. However, from the notice of funding opportunity last November, all of the projects that they requested in there are within the performance measures, so not much of that changed, just the criteria that they were looking for. We submitted a carryover to continue our rural grant funded program. So New York State, probably about 14 months ago at this point, was awarded some extra funding that we had applied for a few years ago related to rural education for PECs, because we do have many rural areas. So last June, we received some of that funding. We started some of those projects, which included having some education developed by pediatrics, so scenario-based education that coincides with using their scenario kits that we bought, one for each regional office. So they correspond. So eventually, as soon as we get the rest of the program done with the funding that was awarded, that'll be put up on Vital Signs Academy, and then educators from around the state can borrow the kits if they want to put on larger classes, but the Vital Signs Academy classes could also be standalone if you had your own equipment. So we're looking forward to having that. We also are building some pediatric emergency care coordinator kits for ambulances, and that'll have a length-based measuring tape, a PD wheel, some communication cards, information on pediatric agitation that was developed by EMS-C Federal, our PAT document that we have developed, and probably some other things that I don't remember off the top of my head. But it is a pretty comprehensive kit. It'll be in a dry bag so that it can be protected on an ambulance, because we all know what happens on the ambulance. And I am currently working with PAG to get those developed. They have been through the EDCC process. I'm very excited that they are approved, and we just need to develop them and get them out there. I am now a part of the NASEMSO Safe Transport Testing Guidelines groups. So as many of us have discussed, a lot of the pediatric transport devices to be used in 911 vehicles have not had any testing because there are no testing standards in the United States. So to be clear, it's not these groups that will be approving testing standards. That will be through CAE as other car seats are approved and tested. This group is working with them. But we will be offering guidance on what is important and what should be tested. So some of those meetings will be happening later in the month. We have been meeting virtually in small subgroups. This will be all of the groups getting together. So that is ongoing. Of course, Vital Signs Academy, we have classes ongoing. We do have an OB series coming up, and I believe that starts at the end of October. Jay Rodriguez from Texas has a larger pre-con that we didn't have room for this year at the conference. So he was gracious and broke it up into 1-hour increments. So we will be having that series of, I think, about 7 classes starting in October going through the new year. And that will cover a wide variety of OB encounters that EMS providers might face. Of course, Vital Signs Conference is coming up. It will be October 18th through the 22nd at the On Center in Syracuse, and I hope to see all of you there. I know some of you are speaking there. We will have a variety of pediatric classes throughout the conference, one of them being safe transport. I believe we have a disaster triage class, and a handful of other ones that I don't remember off the top of my head, but that is live at the vitalscienceconference.com, so you can check it out and go there and look. Future meeting dates. So our next meeting date, so you can all write it down now, is December 4th from 1 to 4, and it will be right here. Yay. So it will be at the Hilton Garden Inn for those of you who are virtually joining us. And then next year's meeting dates, we have started to discuss them. I am working with Teresa and Val to coordinate with CMAC and SEMSCO so that we can have them the Monday before CMAC and SEMSCO, since we will be renting here anyway. And also, very thankful to DLA for allowing us to have 2 meetings virtually. So I'm anticipating the winter meetings will be virtual, because we all come from all over the state, and I know my Buffalo peeps will be thankful to not have to drive in the snow and bad weather. So the winter meetings will be virtual. The spring, summer meetings will be in person together for better driving. And those dates will be coming out shortly so that everybody has time to get them on their planner. Also, STAC will be October 11th at the Egg right here in Albany. Yes. And then CMAC and SEMSCO, the next meetings will be next week right here if you're interested, and that is on the 12th for the committee meetings and the 13th for MedStandard, CMAC, and SEMSCO. Travel information for those of you who had to travel to be here is right over there at the table. It's also in a folder on Boardable under our committee. If you have questions on filling anything out or any of that, please let me know. I know many of you are new to this and many of you haven't done this in a while. So happy to help. And then also, I have some sad news, particularly for me. Jacob has found an excellent opportunity, and he will be leaving us on the 15th. We are happy for his opportunity, but sad to have him go. And thank you so much for everything that you have done for us and continue to do so until the 15th. So that is my report.
Any questions for Amy? Thank you, Amy, for that thorough report as always. And now we move to Director Greenberg.
Which I think, Amy, I think in the future we should always have you go first, because now I won't duplicate everything, and I won't get yelled at by you for saying what you were going to say. So I'm totally okay with that. So just a couple other things on what's going on in the Bureau. Especially since our last meeting, we've had a lot of exciting movement and a lot of things going on. The biggest thing is, Part S and the budget, and I'm sure Mike will probably talk a little bit about that later on. But we did have legislative change that happened in this year's budget, and it really is bringing forward a number of really positive things, including our system and agency performance standards, which has a lot of opportunity for the future, and possibly some things for pediatrics as well, including a state EMS task force, some recruitment and retention things to work on, workforce development within EMS and different things. And as that has kind of fostered on, it also starts opening more conversations for how EMS providers best can be utilized and their expertise and different things. So those are really exciting, as well as there's also now a community paramedicine pilot program that came out, and that was not part of Part S, but that came out in a pilot program really to continue the work that was being done with EO4. So very excited to see a lot of that moving forward and in a positive way. Within the Bureau, we're really busy and unfortunately and fortunately, we have lost some staff, but to good things, to promotional opportunities and advancement and stuff like that. It has backlogged us a little bit, though, so within your EMS realms, if you're a medical director or anything else, and there's some paperwork that's been delayed in processing, please, understand we are a little bit behind than where we normally are. What we are going to put out there is on our EMS forms page, probably by the end of this week, it will show up, is a graph that will show the particular, whatever, maybe it's CME recertification, maybe it's renewal paperwork, duplicate cards. It will show our average processing time and our current processing time, so that if somebody turns and says, well, I sent this in 4 weeks ago and it normally comes back in a week, they'll be able to go and say, okay, hold on, they're averaging right now 5 weeks. So we're trying to be more transparent in that. We'll update it probably bi-weekly, to those numbers and where we are. And we do think that those numbers will, kind of drop down pretty quickly back to what our normal is. But we want to be transparent, and sometimes certain processes take longer. It is clear that our extensions are coming up to times when people need to recertify, because we have about 10 times the number of duplicate card requests going on as providers are trying to figure out, when do I expire? And, when do I need to do my paperwork? So, that is causing some of our backlogs of things, is just a strong spike in certain requests. As we move forward on things, we, at the last SEMSCO meeting, announced a new fee schedule for some of our trainings. So our EMT class training fee schedules went up. We have 4 new pilot programs that I don't believe were discussed with this group, but they include an EMS Academy program where it's an entire EMT class taught in an 8-week period. There's an EMT internship program to try and attract people just to come and spend 8 or 12 hours with an EMS agency and figure out, do I want to go become an EMT? We have an intro to paramedicine grant program that's out there to try and have people, who I think I want to become a paramedic, but I'm not sure if I want to become a paramedic, to get a little bit of experience, and then training for leadership training, or funding coming for leadership training. So we're excited for a lot of those. There's actually another pilot program that is being proposed, and so we'll find out probably next week or so if that one will be added to, and that's from a lot of the feedback that we've gotten from our different councils in moving things forward. In our data and informatics, which Jacob sits kind of on both right now, and Jacob actually, even before coming to EMS-C full-time, he was part of the data and informatics team full-time. They are also going through the lovely roller coaster of staff coming on and staff having opportunities, so they're doing a great job, but you'll see some transitions happening there. They spoke about the trauma world and vital signs, which is in October. So I'm really happy that is going on. Executive Order 4 has ended. That ended in June for us, and that really had a lot of things that allowed us to do community paramedicine, allowed us to do outreach, allowed us to do some things that were kind of innovative, including EMS providers working in what we consider non-traditional environments. And that did come to an end, but we're seeing a lot of other things come up in opportunities, so we're continuing to monitor those, and hopefully we'll have more information probably by your next meeting moving forward. And I think those are the major key points. I will also leave you with just an appreciation to the work that this committee is doing, and I say that truly and wholeheartedly. So for those of you who don't know me, I am also still practicing paramedic with the volunteer corps that this year I celebrated my 30th year with. And I know I don't look like I can be there for so long, but it's true. But we had a call just about 2 weeks ago for a 1-year-old. And it was a 1-year-old who, it was a serious call, but it was, thank God, everything was okay. And it came time to transport the patient. And I looked at, one of our providers and I said, okay, we need, the pediatric device to put him onto a stretcher. And they're like, I know where that is. And not only did they know where it was, but they knew how to put it on the stretcher. And not only did they know how to put it on a stretcher, but our patient was actually cooperative in sitting in the device on our stretcher, which was impressive in itself. I didn't know that we were going to get all three, but it really, as a father who's had to transport his own children literally on my lap because they didn't have a device or anything else, to being a provider who was able to turn and say, we have a safe way of transporting this patient is able to go in the device got put on correctly, and it didn't, it went on smoothly and everything else. I really attribute a lot of that to the work of this committee and the work that you're doing, because it's that repetition of getting out there that really makes a difference. And so thank you for that, both for improving the safety for my children when they have to get, God forbid, if they have to get transported again, but also for my patients, in this particular case, the little 1-year-olds who we had to take to the hospital. So, and that's it. End of report. Happy to take any questions.
Any questions for Director Greenberg? Okay, well, that's good. Okay, thank you, Ryan, very much for that. So let's now move on to old business. And Ben Casper, I think you're up to tell us all about where we are with respect to safe transport of pediatric patients. We already had an intro from Director Greenberg, but let's see what wisdom you have to add to that report.
Well, I appreciate the segue right into that. That worked out quite nicely. So we ended up getting published with an article and revolving around the safe ground transport of pediatric patients. We've noticed that, the best practices through NHTSA and multiple other sources is outdated by about a decade. So a lot of things have changed, but we've noticed, and actually you can go to the next slide, please. What we've really noticed is that a lot of people are, a lot of our pediatric patients, because we have a pretty large catchment area in Buffalo. We have about 8 counties that kind of funnel into us. So we're kind of a regional center there. But we've noticed that there are a lot of patients that were just transported from our nurses, and when I've been working on the streets, just in a way that didn't really necessarily look safe. And so that was the why we really wanted to dive into this topic. And we're going to talk about the objectives, the methods that we use, some of the results and conclusions that we're able to come up with based on what we're able to find there. And next slide, please. So we did the observations through about like a 3-month period of time. We let the EMS agencies know that we were actually going to be observing, and it was non-punitive, but we're just going to observe on the way in which our pediatric patients were brought into our facility. And so it was kind of like a somewhat intentional or subsequent like Hawthorne effect. So they knew that they were being observed, but yet we still noticed that over 50% of them were still brought in by means that did not appear to be safe based on the recommendations that were set forth. And we noticed that they were going on an adult's lap. We noticed that there was a lot of room for improvement, we'll say, because as most of us know that in the collaborative protocols, it's a recommendation, not necessarily a requirement as of right now to have that pediatric restraint specific for ambulances. And there's some interesting ways in which they did come through our doors. But we wanted to know like what the main obstacles, what the impediments were that made it so that they were not able to be brought to us in a safe fashion. Next slide, please. So our objectives was just a qualitative improvement study to evaluate those barriers from the individual, the organizational, and the societal levels, and identify any opportunities that we could actually maybe help provide. And a lot of times, it's always a little bit different when you deal with like New York City and then the rest of upstate. We have a lot of different obstacles. We do have some volunteer-based agencies. We have a lot of paid agencies as well. With the smaller volunteer transporting agencies, finance seemed to be something of a concern for them. Next slide, please. So we did hold 6 focus groups, some with the paid agencies, some with the volunteer-based agencies. We also had interviews with EMS leadership just to kind of see their perspective, and then the focus groups were primarily geared towards the boots on the ground and the people that are actually physically doing the work, not necessarily from that that higher scope there. And we were able to analyze the data and have some common themes through our approach. And next slide, please. And the results were, well, a lot of people didn't really feel comfortable transporting children, whether they aren't familiar with, nonverbal patients or just being able to really kind of empathize and utilize everything they had at their disposal. And there wasn't a lot of knowledge. There was definitely a pretty significant knowledge gap. And sometimes they didn't have the restraint that was needed to safely transport the children. They did notice that the equipment was either unavailable. A lot of the agencies didn't have clear policies on how they were going to be transporting because there was a lot of gray area. And also, you're never going to be proficient at something that you don't do all that often. And pediatric patients, a lot of people indicated that it was maybe 1 out of every 30 patients that they transported was a pediatric one. So there's a little bit more stake in the game when it comes to something like that too. And they think even if they have the restraint, sometimes it's probably right next to the KED underneath the traction splint or something like that, because it's just not used all that often. And that's the one thing that we want to make sure that we're educating those personnel with too. So even we would start with like a focus group, and then we would transition towards an educational session, utilizing the equipment that they had, and giving some recommendations. And a little bit of background for myself too. I'm also a child passenger safety instructor for car seats, and we've done a fair amount of work with that and incorporating that into the EMS world. Next slide, please. we realized that one of the main things was that EMS clinicians needed the hands-on training because you have to be able to do something and be familiar with the equipment that you have and find out how compatible it is with the gurney or stretcher that you do have. And there also was the need to ensure that the crews had the proper equipment, the training, and essentially the protocols in place to make it so that we had to do this. And then also to have part of like a QI process, to have it something where you can kind of, you can't really QI things that you don't document, and to have that as a potential drop down or something like that as a mandatory field, and EMR would be, or an PCR would be beneficial. But also changing the whole theory behind it. You have a lot of people that they just, well, they don't even wear a seatbelt themselves when they're not dealing with a high acuity patient. So there's some other factors that kind of go into that. But I know that both Amy, myself, and a lot of other members throughout the state have been kind of working towards what this model could hopefully look like. And I think that's great that, because there's a lot of devices that are out there, and they're not all created equal. And some of them, just from an observation standpoint, don't look like they would restrain much of anybody. So there's definitely some more work to be done. Just a couple of the quotes, though, that kind of stood out a little bit was that, you know, kids freak me out, to be honest. And oftentimes it's hard to work with a pediatric restraint, especially when the kids are not calm. So we kind of worked through a lot of those impediments as well to incorporate patients and their families to help them restrain maybe not the highest of acuity patients, because they're all used to being in that similar kind of 5-point like harness anyway from being in a car seat, which we think that can really benefit as well. But I'd be happy to take any questions at all or any comments.
Two comments. Well, a question and a comment first. First, would you be kind enough to forward a PDF of your paper to Amy so she can distribute it among the group? We'd all love to see it in print and be able to review the data in detail. And second, I just learned from Amy that there is a session on pediatric transport at Vital Signs where opportunities to, learn how to safely transport pediatric patients, is emphasized. So just to make everyone aware that that is part of the Vital Signs Conference. So for those of us around the table who are our EMS provider colleagues, please spread the word so that people are aware that this training is available, and I'm sure it will incorporate many of the issues that you and your colleagues in Buffalo have identified through your research. So that's really wonderful, information for all of us. I just want to note parenthetically that not the first time, but one of the more in-depth times we considered the issue of pediatric transport at around this table goes back to the late 1990s. When Dr. Nadine Levick, an international ambulance transport safety expert, was actually part of this committee, and she brought this information to us at that time, or some of this information to us at this time. It's remarkable both how much has changed and how little has changed in that period of time. I would say that if 50% or thereabouts of the folks that were hawthorned, shall we say, into transporting infants and children safely, if that's generally the rule in Western New York with the large catchment area that you have, then we're in much better shape than we were back in late 90s. But that was more than 25 years ago, and only 50% are with it. So we've got a long way to go, and I know that the EMS provider leaders around this table will pick up the ball and run with it. I know Chief Pataki will ensure that his colleagues at the EMS Academy are really on top of this, as I'm sure they already are to some extent. But with this new information from Ben Casper, I think it'll be an opportunity to improve, the training at the academy, which has always been great, to an even greater extent. And I know Sharon will pitch in the Rochester area as well, making sure that that this happens appropriately and so on. So thank you so much, Ben, for that presentation. Director Greenberg.
So Ben, by the way, thank you for the knowledge, and like I said, I think it is working, at least to some effect, as I've watched it locally and personally. So what do you think next steps are? So you bring this up in, here's some great data, it's 50% of the time. By the way, it's 50% of the time when you told them that you're watching for it. So my guess is it probably wouldn't be as high, maybe if you didn't tell them ahead of time. Maybe, I don't know. But what do you think, both locally and then statewide, would be something that can move forward with this?
So, great questions. Well, what we decided to do was to let everybody know, because we've noticed that, potentially there was some EMS leadership that did state that they had the devices readily available. But then there was also some boots on the ground that maybe didn't have accessibility to that to the extent that it was portrayed to us from the higher leadership. And so there was actually, we noticed that EMS agencies changed the way in which they kind of did business. Like, there were certain agencies that any pediatric patient, they would have, if it was an ALS level rig, that they would actually have the ALS provider in the back, so they'd have the most experienced person, and they would emphasize the need to safely restrain the child. But then also some of the other agencies made it so that their local ground ambulances were equipped with the necessary restraint devices. So as far as next steps are concerned, I know everything, or a lot of things, it's only fair to start as a recommendation and then have it go forward as being a requirement. And I think because of all the awareness that has taken place throughout New York State, we would love to see that it actually becomes a requirement to have these devices after we have the answer to what devices would be safe and adequate, because there are a lot of knockoffs, or there's a lot of lower price point options that don't necessarily provide with, like, say, metal clasps. They'll have like a plastic, like the 9-foot straps, how they have the plastic there. And again, I don't know the durability of something like that, but
sure.
I would think that we would need to locate maybe characteristics of an acceptable restraint, or something along that line, which I'm really pleased that Amy's partaking in a national group that is going to be kind of looking at what would make an adequate restraint, and but then making it so it's a requirement. It's nice that it's included with the CME, for the CME research, to have 1 hour of pediatric training for safe pediatric transport. So I think that we're making slow but steady progress, but it would be nice to see us kind of make that leap once people think that we're in a good position to do so.
And I can tell you that the new equipment standards, which are most likely, they'll go out for public comment in the next couple of weeks, hopefully, they do state for anything from 10 pounds to adult size to have a pediatric device. Again, that's going out for public comment, so anything can change in that process, but it is there and it's listed in there.
I might just add in for a moment. I have the pleasure of sitting on that committee with Amy. We're probably several years at best away from a formal recommendation, especially being conscious of the fact that these products are, the manufacturers of these products are active participants in this in terms of lending equipment and helping design some of the evaluations. But I do think that, and I'll defer to our data expert down the road from me. If you want to evoke change, you have to pressure it a little bit. We've been talking about this. My EMT basic course was in '98 or something. We still don't do this well. Back when it was an EMT basic. But I think that for my data colleague, I guess my question is it a mandatory reporting field about the safe transport? And if it's not, I wonder whether both at the state level and the next version of NEMSIS down the line, whether we consider making a recommendation that the mode of transport for pediatric patients becomes a mandatory field. Because if you want to give somebody a report card of how well you're doing something, you have to make it mandatory. Not necessarily the use of it mandatory, but the reporting of it mandatory. I think we saw significant improvement in things like back in the day for finger sticks for pediatric seizures and for EKGs for chest pain, once it became something you had to report out on, it became much more prevalent and ubiquitous. Thanks.
Before I recognize Doug, who's next, I just want to ask Director Greenberg, I could ask Dr. Harris if he wanted to make a motion to that effect, but before I would do such a thing, I wanted to see what Director Greenberg and Ms. Eisenhower had to say, because I think they both have something to add.
So to answer if we are tracking that data, in the upcoming changes for moving to NEMSIS 3.5, EMS-C works with our data informatics team in creating some of those standards, and one of our requests was to add that into the section of the chart where you document how you transported that patient. So I believe currently, and Peter, correct me if I'm wrong, currently it says car seat. Yeah, so currently it says car seat. We propose to add pediatric restraint device, patient's car seat, and I believe neonatal restraint device. So we have requested that to be added into that standard, and that work is ongoing.
Just food for thought, and just in recognition of the fact that there are agencies, not just in New York, but around the country, that are financially limited. If we want to really define practice, they're still putting people and kids on parents' laps. So I think if we want to define the current state, not necessarily the recommended state, but the current state, I would add in something that says, caregiver's lap or something there, even though we clearly want to be, I want to be aware that we don't want to make this look like it's something we approve of. But if you're really looking to define the current picture, just food for thought.
I think we have some more meetings coming up, so we can bring that back to the group and discuss.
Yeah, I would be concerned about that, because the implication would be if it shows up on a pre-hospital care report, it would some people might take that and say this is an appropriate choice. So
I think it's a valid point, Dr. Cooper. I think that I worry, similar to vital signs, that first of all, I think they're only going to document it a third of the time if it's not required. But I think it's an interesting. I don't know if I have a great answer to this question. Just to recognize that what they're documenting, if they're doing something that's not available on the drop down. I think I've proved my point.
So just to touch on that one, and for all the EMS providers who are out there hearing another mandatory field, we are particularly, we are really watching to reduce the number of mandatory fields. So rather than increase another mandatory field, what we're doing here is within a field that is mandatory now, we're adding more options to that field. So instead of just being I transport on a stretcher, it's I transport on a stretcher with a pediatric saving device. In addition, I don't know that on-lap or not on-lap really would be that significant, because reality is I either put them in a safe transport device or I didn't. And once I didn't, whether they were on a parent's lap or not, I think would, still be in the same category if they weren't transported, unless there's a defined reason, right, in that device.
One final point, Doug, before I recognize you. In terms of further discussions about this, Amy, I would hope that we would include Pamela Foyer and Ms. O'Toole. Pamela, because of her longstanding experience taking care of kids with special health care needs in terms of their transport needs, and Ms. O'Toole in terms of being the parent of a child who may have needed special transport considerations. So I would just ask that they be considered as part of the work group. Doug, and then I just have another point to make. Go ahead.
As Ben was saying, pediatric safe transport is now part of the CME program. Is there any discussion about adding it to the initial training, adding an hour or two into EMT courses and a review into a paramedic course?
So, unfortunately, not right now. Now, that doesn't exclude any EMS program from doing that and having it as part of the course, but it's not part of the initial. And there are many things that we, I think, consider for the initial, but the number of hours are capped on how long an initial class can be, and the amount of content seems to keep increasing. And there's part of me that believes would it be great to be part of your initial training? Absolutely. But the other half becomes, and I think, Ben, you were talking about it, the number of different devices. It really becomes an agency responsibility to make sure that the person, the ambulance they're working on is trained on the equipment that they carry. And, I think that was kind of just, proven even one step more on my volunteer agency. It was not only that we had it, but we knew how to put it on. And it only took once or twice of looking at it and turning it around and being like, okay, yes, I'm putting it on the right way. So, I think there's that side of it. I think if, would it be a great addition? Absolutely. And I think that's what we start to get at. Keeping in mind right now we have almost a quarter of our EMS providers, a third of our EMS providers in the CME program. So, it is, hitting a lot of that population just through that as well.
Thank you. Peter? Brody?
Dr. Cooper?
Yes, sir.
Just an additional comment.
Go.
This comes up several times, and I notice that we're referring to kids 10 kilo and greater just because of the difficulties, obviously, in the preponderance of kids who are transported are in that age group. But I wonder if it's time to readdress the newborn. I feel like this is something that happens in our agency several times a year for the child who's born at home, the precipitous delivery, and the sort of interesting discussion and conflict around safe transport of neonates and juxtaposing that with the needs of like skin to skin and so forth and other things that were more in that pediatric context. But I think this is a group that we don't have a great mechanism for transporting in general. And the options are obviously much more limited. There's obviously financial considerations for these devices that go down to that sort of 3 kilo range.
Director Greenberg. Oh, sorry. Elise.
Yeah, first of all, congratulations, Ben, for presenting that and doing that study. Sometimes it's really hard, I think, to do things at the statewide level because there are so many implications and places are so different. So I'm just sort of wondering a little bit what you were saying, Ryan, was what are you doing locally with this information? And an example, for example, have you brought this to the attention of the regional EMS council there? As this is what pediatrics is really critical to have this information, even though it is only qualitative, it is not an objective, quantitative, what % of ambulances have it. Is there something that you can do, at least locally, bring it to the attention of your regional EMS council, and then have some dialogue on how to get either more objective data, or even more importantly, how do you break into something at a smaller level rather than the entire state, so.
Very good question. So what we did was we were fortunate enough to have funding for 20 pediatric restraints, and we were able to give them to those agencies that were in need, that do handle transports and that were in need. And so we, at a local level, we're fortunate enough to receive an endowment through Kiwanis that we can participate in injury prevention and different types of needs on an annual basis. So that's one thing that we were able to do, and then also provide the education with the devices that they may currently have, or instill the appropriate use of those devices. And it's a pretty open door policy where they know that they can reach out to me, contact myself or our local trauma department. And we did make it aware at our local REMAC that that we were doing this study, and that we were there to help for those agencies that maybe did not have the financial means to purchase them themselves. And then just to answer to the newborn, or not to answer, but to at least give a little bit of input. It kind of goes into a couple of different buckets where you have like the ill or needs resuscitation newborn, which then you would be separating mom from child. But then for the majority of the cases, at least that I've delivered, the skin to skin, there are wearable devices. I can't necessarily speak on their, I believe that they do advertise them for use in ambulances, and some are disposable, some are able to be cleaned, and I really wish that those were available, because I'm not even going to mention on record how I've transported all of the like 5 to 10 newborns with they were hemodynamically stable So there's devices that are out there, and I think that that is a significant gap, and that's something that we would really love to see, or I would love to see addressed as a package of. But I'm sure Amy might have some input.
If you came to Vital Signs last year, you'd see me on Sunday morning wearing the device, literally on stage. My Sunday morning, she said, Amy walked up to me, she's like, do you want to wear it up on stage with you? And I was like, sure. And she has this realistic baby. Well, you don't realize how realistic it is until I'm on stage with this doll and I'm shaking as if it was my kid, kind of trying to rock it to sleep. It got the point across, I think. So, when we talk about things that we can do statewide and things here, and Amy, I'm not going to make eye contact with her because I'm going to make a suggestion to do something. So if I just look this way, it's much better. So one of the things that could be interesting for this group, and not on the short term, but even if it took a year to get through, we are moving towards having these pediatric devices on every ambulance. It is going to become a standard that the safety committee from the SEMSCO has come out with. And is this the right time to start thinking now about possibly doing a similar poster to our mental health posters, but, a pediatric safe transport poster, and it show maybe a number of different devices that can be hung up in a station that, to kind of get people to think about it, and then possibly even a smaller one that just says pediatric safety device is located, and a blank box that can go in an ambulance that can be like, it's underneath the KED and the other thing, but it's there, so look for it. That could be, I think we might even have some funding for that, and might be able to find some funding, but that could be a statewide initiative that would have all of our agencies thinking about it and know where to find it when it becomes required.
So I think that that's something that we could certainly ask our transport group to think about and perhaps develop. Chief?
So downstate, we have ambulances that come from the manufacturer with, safe transport devices for pediatrics. As part of your study, has there been any consideration to, perhaps lobby the manufacturers or make recommendation to the manufacturers that all new ambulances come equipped to transport any type of, pediatric patient?
Absolutely, that would be, well, that can be a driver of this initiative. And as more states or some states come on board with making this a mandatory field, I think that will be something that a lot of manufacturers will try to, have that as part of their package as they, take a pre-existing chassis and, design it in a particular way. But yeah, I think that, reaching out to some of them, but I think that just due to the gray area of being, I would argue, a strong recommendation, but not necessarily a requirement, and a lot of healthcare is kind of working in the red right now, so it's, especially in New York State, so it's a little bit difficult, but that's a very good recommendation. Thank you.
Yeah, I mean, certainly it doesn't, it doesn't fix our problem currently, right? We're going to have to get another device that goes on the ambulance, but maybe mitigating it for the future, so we, maybe 10 years down the road, the next committee won't be having the same conversation.
Excellent. Thank you.
Chief, is that something you think you believe we should potentially write a letter about?
I was thinking, I hate to use the word, interim recommendations, right? Because any recommendations that come from this committee, obviously they hold weight. But I think that starting the conversation now might have implications for the future. We let the manufacturers know we're looking at this, and this is something that maybe they want to get behind and work with us, as opposed to us going to them after this is all done.
I'm just going to suggest sort of an interim step, if you don't mind. Amy reminded us earlier that she serves on the Safe Transport Group for the National Association of State EMS Officials, right, which has obviously, I think, probably a greater sway with the ambulance manufacturers than just an individual EMS-C committee. So do you think it would be okay if we, as a committee, made a recommendation that we write a letter to the NASEMSO leadership and ask them to take it up as a, I think there's no reason we couldn't write a letter ourselves, but I think it would carry a lot more weight if NASEMSO as a group and the state EMS officials all got together and said, hey, this is really important, ambulance manufacturers, we really need you to do this. Does that work for everybody? Is there any,
Yeah, certainly.
is there any objection to putting that letter together? Mike?
Could I just make a comment?
Sure.
I sit on the NFPA 1917 committee, which publishes standards for automotive ambulances. And there are two standards, the NFPA standard, the CAS standard. Both of those recognize that there is only one manufactured seat that's approved by SAE, the Society of Automotive Engineers, to hold a child. So NHTSA, working with NASEMSO, this group that Amy's on, now has a multi-million-dollar grant where they are approving others that they have collected from manufacturers across the country, and that study is ongoing now. That will identify a whole host of devices that actually get federal approval to use to secure children in ambulances. And it might be better to wait until that list comes out, because to recommend a device that's not SAE approved now is a tremendous liability.
Yeah, I wasn't suggesting that we recommend a particular device, merely that we, write to NASEMSO and say, hey, this is a really important issue. Can you, make sure that ambulance manufacturers are thinking about this and, make plans to include appropriate approved devices, blah, blah. And of course, we would have to wait for the list, as you point out, Mike. But is there any objection to sending the letter? Well, hearing none, we'll go ahead and send it. Okay, thanks. Why don't you and I work together on that? Okay, Amy and I will work together on drafting the letter. Before we get on to the rest of the agenda, which is pretty lengthy, I can't help but comment that there are sort of niche kind of EMS practices, that we often talk about, and say, oh, just do X, Y, Z, whatever it happens to be, but the training for those practices is not always the most robust. The one that comes to my mind most frequently is, and from teaching HLS and PALS rather frequently, is needle cricothyroidotomy. How many people have actually ever done it? Very few. How many people would know how to do it if they actually had to do it in a pinch, because, the equipment that's available for it is always locked up in a closet someplace, and it expired when it finally gets pulled out of the closet, and you always end up having to jerry-rig it. So I'm not suggesting at this moment that we do anything about that, but I am suggesting that there are niche issues like this that do pertain to pediatrics in particular, needle cric being one of them. That is something that is food for thought and potentially requires some action on our part in the near future. Okay, so unless there's anything else on this, let's move on to the PAT document review, the Pediatric Assessment Triangle document review. That's Dr. Vaudriat and Sharon, I believe.
Yes, thank you, Dr. Cooper. And indeed, this is work that's presented by Sharon Cimento and I, who were given the charge to review this. The PAT, the Pediatric Assessment Triangle, for those of you who haven't been here before, has been used, I think, now for many, many years by especially EMS providers, as I understand it. And what we had found out as we reviewed the materials, that it had not been updated with respect to the latest PALS, American Heart Association guidelines. So we were asked to look at this again, to review it, and to see how we could improve it. If you could move that up just a little bit, I think, Amy, or whoever's got it. Yeah, right about there. I don't know if you can make it any bigger and put it in presenter mode so we can see it a bit better. Yeah, just remove that sidebar. Oh, it isn't? Okay. So if you, and I can't control it myself here, if you look under, everything was pretty much the same, but there's a few things that there were some changes made. Under respiratory or cardiac arrest on the right side, as you can see there, the ventilation recommendations of the AHA have been incorporated into that for infant and child. And that was a really pretty major change in the 2020 guidelines. So the 20 to 30 breaths per minute rather than the sort of 10 to 12. So that was really important. On the blue side, we did some formatting changes. That pretty much is similar in the neonatal resuscitation. But if you notice, if you move it down now one more time, Amy, go back where you were before. A little bit further. with all this on blue. So we did a lot of reformatting, rephrasing, making it a little bit more clear. This all incorporates all of the AHA recommended changes in a more streamlined fashion. I'd like to point your attention to on the left column there, and we'll just start there. As you can see there, under the asterisked area, it says you can give the epinephrine endotracheally. And it specifically talks about the concentration of 1 milligram per milliliter, which is 1 to 1,000, down the endotracheal tube. This is repeated in the second column under bradycardia. It is also repeated under the VF pulses V tachycardia column. The issue then became when Jeremy Cushman reviewed this on the behalf of the EMS protocols. He actually recommended removing anything given endotracheally in those three columns. So that was a big thing. He scratched them all out, recommended they not be included. And then also he excluded or recommended for exclusion in the last column where it talks about lidocaine IV and magnesium IV, that those also not be included in this document. My response to that was a bit, okay, if it's exclusively talking about EMS protocols and there is never anywhere in the state opportunity to give anything endotracheally, for example, then maybe that makes sense. But I think the other thing, as I remember, that this whole document was designed not only for EMS providers, it was also for any provider who was able to give these kinds of medications, potentially even emergency departments. You also see at the very bottom of this document, this in red, very specifically, and this has been there, this is not something we added, as I remember, but this reference card should not replace or supersede regional protocols, because we were very concerned that this not be seen as a protocol or a sort of mandate. This was really an educational tool to be used pre-hospital, which is largely where it's been used, but also emergency medicine or any place else where these patients would come. So the question for the committee is it okay the way it stands as it's portrayed up here, or should we remove any medications for endotracheal administration, and then also remove lidocaine and magnesium IV? I don't know if that's a clear question, but I believe Sharon, I think that's how we ended up with this. Yes, Kevin.
I'm just curious, what was the rationale for removing endotracheal medications?
The rationale that was given that those were not consistent with our collaborative protocols for advanced life support providers, that it was not in the protocols. So that assumed, I think, underlying that, the assumption was that this was only for these protocols, and since it was not in the protocols as a formal part of the protocols, that therefore it should also not be reflected in a tool that was sort of identifying this as the tool to explain the protocol only. That's the only reason why we have this tool, rather than it's broader than just the collaborative protocols, if I make myself clear.
Thank you.
Okay. Yes.
Just, I think the document is phenomenal to begin with. As far as the ET tube administration of medication, I definitely agree that is not in protocol. Just looking to my emergency medicine pediatric colleagues, is ET tube medication administration a routine practice, or with the advent of IOs and other access in the hospital, is it routinely given intravenously? And if that's the case, and we're going to look at this as a tool to be utilized across multiple emergency medicine disciplines, pre-hospital and in the hospital, should that stay or go? That's just my thought on it. And I would actually recommend that we keep lidocaine and mag in this document as well. Just thinking that if the ET route of administration is not used across any of the disciplines, that maybe that actually does get stricken. Just a thought.
That's very helpful, Jason. I really appreciate that. And there are others who work in the emergency medicine room that are on this committee. But I can tell you, being involved in resuscitation for many, many years, there are certainly pediatric patients where IV access or IO access has been very difficult. Recently, even in the last 4 months, I had a patient, even on the inpatient, who arrested in an MRI. I happened to be the person on scene, and the patient had no ability to give anything. IV infiltrated, IO was unsuccessful. Now what do? The kid was intubated, so you give endotracheal. So I think those things do happen, but I would certainly appreciate the opinions of Dr. Caleo or Dr. Harris, who work in the emergency medicine field.
Fortunately, in my career, I've never actually had to give anything endotracheally from a medication standpoint. Typically, if we can't obtain IV access, IO has been successful in at least all the resuscitations I've been a part of. I do know colleagues who have used endotracheal medications before, though it is quite rare. So I would say it's not something that I do on a routine basis, though.
Yeah, I'll just echo what Vincent was saying. I've never done it, either as a paramedic or as a physician.
So kind of to follow up on Jason's comment then, if some physicians have seen it, but others haven't, would it be better to keep it on this document since this is supposed to be a tool, right? A reference tool to, right, kind of to jar your mind to say, we could do that. I mean, would that be helpful in your environment? I know that's the intent of this for EMS providers.
I will say, I'm the co-editor of PEP, the Pre-Hospital Pediatric Emergency Textbook, and in the edition that just published last year, we kept the endotracheal piece in there as a suggestion should you not be able to get venous access.
I think that is extremely helpful, actually, because I think when this first crossed my desk from Dr. Cushman, it was like, well, this was never intended to be very specific only to the collaborative protocols. It was an educational tool that could be more broadly used. And that it's really helpful in support of the general usefulness of something like this, if it is in a pre-hospital text, that you have just suggested, it might be best to keep everything the way it is, but then be very clear that red-lettered statement on there, it is not a replacement or anything that supersedes the regional protocol, because you may be in an area where you have some differences, and you can never supersede that. This is purely an educational tool. So.
Other comments?
I just have one for formatting, just because I like how the amiodarone, lidocaine, magnesium, how that's displayed, but as far as the epinephrine, and if somebody's looking, they really shouldn't be looking at it as for the quick guide, but if they are, it might almost be nice because obviously the ET, if you're going to be giving epi via the endotracheal route, that's you're giving 10 times the amount. So maybe even leading with that and having it underneath the IVIO. I just would hate to have somebody take a quick glance and give unintentionally 10 times the medication to via the IVIO route, just from not reading it correctly. But that's just a personal opinion.
Okay.
Just want to make a comment. Having done innumerable resuscitations in 35 years, et cetera, and anaphylaxis is one of the issues that nobody ever gets correct.
Correct.
There's literature on it. People fumble with which epinephrine do we grab. So I think from an educational perspective, and I would probably disagree and not note, you've already got the difference in the dosage. Once you put another sentence in there, this is 10 times, somebody's going to be like, 10 times that dose, this dose. Again, it's sort of a last-ditch effort. I've probably done it on one hand in a PICU in 35 years, but I've seen it done recently in the DR and in a precipitous delivery where nobody could get access. It was kind of a mess, and it was helpful that people with gray hair remember that you can give some of these drugs. The danger goes back to the days when we were taught the acronym NAVAL, and then Valium was the one thing you shouldn't have put down there with a pH of 12. But again, with Narcan becoming so popular and what's out there, that's another drug that, if you don't have an access site. So, I think from an educational perspective, I think it's a good idea to have in there. I think we have to make it simple, because epinephrine, I see errors made all the time.
Yeah,
You know,
we struggled a lot with the formatting of this. I mean, what I'm hearing is we should keep the endotracheal administration, we should keep the lidocaine and magnesium, and then the question is only a little bit about the formatting. How do you differentiate the 1 to 1,000 or 1 milligram per ml epinephrine versus 0.1 milligram per ml epinephrine? We chose to do it with asterisks, you know, to be the better way to do it that way. And we did do the IVIO first, you know, and didn't do the ET until later because we felt that that would be that way people would look at that first, that 0.01 milligram per kilogram IV or IVO, then an asterisk to show exactly what concentration they should be using. But that's a formatting issue, as obviously you say.
I don't know if anyone's used this, but in our children's hospital, we've changed it in the order to cardiac arrest epinephrine and anaphylaxis epinephrine.
Yeah.
Just because I think in the moment people forget which is 1 to 1,000, which is 1 to 10,000. And it gets even more confusing with our epi spritzers, which are 1 to 100,000. But anyway,
And we have, I would add that in our institution, we have done away completely with 1 to 10,000 and 1 to 1,000 because it's very confusing which that is, and we are strictly in milligrams per milliliter. But that being said, the labeling is still a problem, and so that's why we kept it in here after thinking maybe we should remove that funny ratio that makes it really, really confusing. So,
Dr. Foyer?
Yeah, hi, Elise, thanks. I'm going to be a little picky here, just in reading it. The abbreviation for milliliter should be small m, large L.
that's an excellent point.
And from reading it, it'll be less straight lines going all up your gut.
Okay, so no, that's an excellent point for safety reasons to have it M and then capital L. Is that what you're saying?
Yep.
Dr. Foyer? Yeah, that's a really good point. Thank you.
Elise, you know, I'm going to hark back to the day when Marianne Gauchy's study on endotracheal intubation first, you know, came out and told us that we didn't need to intubate everybody. And most of our protocols ended up saying, you know, intubate only when other methods of airway control are not effective. Perhaps some kind of guidance like that in an asterisk that says, you know, only use endotracheal, only use the tracheal route when endotracheal route when other methods of administration are not effective. I think it's implied the way you've structured the document, but I think a comment like that might be very helpful. Thank you. Amy, a question for you and for Director Greenberg. I am not sure, I don't believe this would need to get approval by CMAC. Certainly for information, it would be an important thing, but you'll tell me about that because it is not, again, it's not a protocol, it's a guidance document or a tool of some sort. That's question, or part one of the question. Part two of the question is if we ask Elise and Sharon to take the suggestions back with them, will we be able potentially to approve this at our December meeting since it's going to be virtual rather than in person? Will the DLA allow us to do that?
So to be clear, our December meeting is in person right here in this room.
Sorry.
But
It's next year. Okay, got it.
Yes.
Sorry.
So any of our meetings, we're still able to make motions and vote. Currently, this is the EDCC approved document that I believe our committee met last year when Sharon and Dr. Vanderjack went through and did these revisions. The conversation that came up with Dr. Cushman, he was adding in information on pediatric assessment triangle, and used this as kind of his reference on what we had already done, which alerted him to that these things were not in the collaborative. So he had just sent back some comments to say, can you guys discuss this? So if Sharon and Dr. Vanderjack want to go back through it, make any edits, I don't know the date when I would need it back by to put it through EDCC. I haven't gotten that far. I was dealing with today. But if they give it to me in enough time, November 1st for December 4th. Okay, let's say end of October. End of October. just so that I have enough time to do all the things. Yeah, end of October, if you can get it back to me by then, we can get it in and we can discuss this, continue to discuss this at our next meeting and vote on it.
Thank you.
Time-wise, that's fine. But I did also want to make one other comment, and that is, my recollection is when we did this card originally, years ago, that this was basically to tie in with PALS and not to tie in with protocols. So that might be another thought here.
Yeah, I would not poke the bear and send it to CMAC or SEMSCO. I would just approve it here.
That's certainly fine with me. I'm just making sure that the refs to my left and right are okay with touching the ball in that manner.
I think you can send it over to CMAC and say, this is what we're moving forward with, and if you see any red flags, then I think that's cordial, and especially considering you see a lot of the protocols come this way. But I think it would just be more an advisory of this is what we're moving forward with, and if you see any giant flags on here or something else. If you, and I don't know if it says it on there because it's partially cut off, but probably something, and it might be at the bottom there, I just can't see it in red, but just that it doesn't say that it's protocols. Yeah, okay. Just making sure that, just making sure that it's clearly stated and that it's stated on both pages, not just one.
Maybe that could be in capital letters and a little larger and a little redder. No, just kidding.
Perfect. Thank you.
And I do think that if it is presented to CMAC, it needs to be, whoever is presenting it should present it that this is not a tool to be used only with the collaborative protocols. I mean, I think that's really important, that it's not attached to that in any way. It's almost like it should be independent and say, this is a tool that we have agreed, EMS-C has agreed on, educational tool for all EMS providers. And it's based on, like Sharon said, on PALS and what is state-of-the-art resuscitation. And then maybe even not even link it to the collaborative protocols formally, because someone may walk away with thinking, well, this is a collaborative protocol tool, when it's really broader than that.
Okay. All right, so let's good progress on that. And again, as always, Elise and Sharon, thank you for your incredibly detailed work on that. And we will look to make a final approval at the December meeting, which again is here, okay? And we will need a quorum. So don't even think about not coming. Okay, Sharon, I think you have an update for us on the pediatric agitation issue.
So back in July, the subcommittee that was going to be working on this project did a virtual meeting, and we talked about several different things of directions to go. So just as a quick review of what some of the things that came up at that meeting, we thought that we needed to, Dr. Foyer was going to reach out to EIIC to see if they had an EMS script that we could use to do a video, to do scenarios in a video. I know that she reached out. I don't know if she ever got any results back. So
This is Dr. Vera Foyer, not Dr. Pamela Foyer, correct?
Oh, sorry, Vera Foyer, yeah. Sorry. Didn't realize it was two. Okay, so that's one thing I did not read. I only heard that she had reached out, no results. So I don't know whether they actually have given her any of their scripts. Chief Pataki did reach out to FIDNY to ask if we could use their AV units to produce the videos, and I believe you received a positive result there. I then also reached out to Dr. Cushman in Rochester, so Dr. Jeremy Cushman, who's been mentioned previously, is the EMS medical director for Monroe County, and so he has done videos in the past. He said that they would be very happy to produce things there. However, he felt that the editing might be an issue, so if FIDNY would be kind enough to edit the videos when they were completed, that would be, that would be very helpful. Okay, and he also said that he had a lot of resources that could be utilized. So he mentioned the 911 center, EMS agencies, fire department, first responders. He suggested something maybe where a school fire alarm had been pulled or a fire had been set, and that's when the patient was brought to light at that point. He also said he could involve the Monroe County Sheriff's Office and some other individuals that participate in the mental health responses in Rochester. So we do have a mobile crisis team that goes out, and so he believed that they could get some individuals from that team to assist us. And also the Behavioral Health Access and Crisis Center has a waiver to accept 9.41s, I don't know, some kind of legal thing. And so they're going to be expanding next year, going to be open 24/7, and they will have adolescent capabilities, so he felt that they could be a resource as well. He said that they'd done video training in the past on extreme agitation and delirium, and so he did at that time not only find providers that would helped him with that, but also some of their children, so they could be actors in the video. And he also had some acting students from a local college, because I know one of the things we discussed in the subcommittee meeting was where we are going to get actors, what kinds of people could participate in making the videos. So, he does have some resources, and as I said, is quite willing to assist us with this. We did discuss the need to reach out about funding, and I don't know if anybody contacted you, Ryan, about whether there's any possible funding here for the production of these videos. Also, we did talk about the potential of whether or not this could become, so in the research, CME, the CME-based research, there are usually some required 1-hour presentations, and whether or not this could be in the next round, when you select topics for that, whether or not this could be one of the topics for that once we get this put together. And so, let's see, I think those were the things that we talked about that people were going to kind of reach out and to accomplish. And then our goal is to then decide what content would be included in the presentations. There's a great PowerPoint that Fidney has put together already. I did look at it to compare that against the collaborative protocols. There was no conflicts at all. There's a few things that were in the collaborative protocol educational portion that I think we can add to the Fidney PowerPoint, as well as we would need to change headers and change the stats. There's a slide with some New York State, New York City stats. We could probably change that to either New York State stats or federal stats. And then also we could potentially, there was a statement about, let's see, whether or not we would need to decide, because there's protocols that are in there, we would need to change those to the collaborative protocols on those particular slides and decide what portion of our protocols would be involved in that. So those are some of the things we are planning for the future. And then, of course, in the production of the video itself, finding actors, locations, and the production resources, which we've already started. When this is all completed, what our hope is that it could be a 1-hour class on the Vital Signs Academy. It could be offered as a presentation at Vital Signs itself, as well as regional conferences, such as the STEP conference, and since I'm in charge of that one, I can very easily make sure this goes there. And then making videos available to the EMS instructors to use in their classes themselves, both the research classes and the original classes. So that's kind of our general goals. We now need to kind of start to finalize this and kind of come up with what are our exact objectives, all of that kind of thing. So, but this is just kind of an overview of what we've accomplished so far. And I would really welcome your input here.
Thank you so much, Sharon. That's, tremendous, detailed work as usual from you, our Cantor Award winner. Just one point that perhaps didn't come through as clearly during Sharon's remarks as at least as I remember them, or remember our meetings. As we were thinking about the videos, we wanted to have videos not just from downstate, but also from upstate, so that our colleagues who practice more in rural areas wouldn't necessarily feel like, well, this is just a New York City thing. We don't have any behavioral emergencies here. It's just those crazy people down in the city, right? Of which I am one. I think that that's something that we should definitely consider, and maybe making one video focusing on one aspect of the issue downstate and one video upstate, if we have the ability to do that funding wise and so on. And Sharon, I am hoping that we can move along with this really super quickly. Now that we pretty much have the details all worked out on the pediatric assessment triangle card, more or less, mostly more, that we'll be able to get this done. I really don't want to, on behalf of the committee, I don't think any of us wants to see this, drag on too long. This is such an important issue for all of us with the, COVID just brought this to the fore, but the mental health issues for children have always been there, and we just never really focused enough on them. So this is our chance to really shine. Any other comments or questions for Sharon, who's done her usual outstanding job? Chief.
Just a comment. Happy to report that the fire department did agree to essentially, promote this video, to produce it, to edit it, and there would be the ability to travel as well. I can't say that our Buffalo friends, we would be shacking up with you, but we would certainly make some concessions to try and find a place that's more central in New York. The details would certainly need to be worked out, but I have complete support from the leadership in the fire department in order to help produce this video. So however we want to move forward, I think that we have overcome. We certainly need to look at the funding for long term, Ryan. But
why is everybody
Amy?
Yeah. But, in order to produce a video in short order, I think we have the ability, we certainly have the resources, and I agree to hit on what Dr. Cooper said before, is this has to be a video that encompasses all state EMS providers. This isn't a fire department video, down in New York City. So I think that with that ability to travel, with that ability to get everyone involved, we can produce a very good video for the providers out there.
Thank you, Chief. Other comments? Okay, well, Elise, go ahead.
Yeah, I just have a question. Sharon and I were talking about this actually out before the meeting. So when you develop that video, do you have clear in your mind what the instructional objectives are? In other words, what are the specific things that need to be addressed in the video? The content, in other words. Is that clear to the group that you're working with?
I definitely believe so. We've been discussing this in our separate meetings, and I think we have our goals of what we're looking to achieve, and then the scripting comes into play, and that's where Dr. Foyer was going to reach out and speak to see if there was a pre-existing script. So we wouldn't ad-lib it. We wouldn't develop it on our own. There could be something out there that we can utilize just using providers throughout the state. But certainly, I believe, and my colleagues on the subcommittee, feel free to chime in. I believe we're all on the same page that the goals were clearly established.
And also to jump onto that, Dr. Vera Foyer, who is in the vetting process to replace Dr. Jennifer Havens, who got a promotion and resigned from our committee. So she's in the process, but she has been helping us. She was in the group at EIIC, so the EMS-C federal group that developed the pediatric agitation standards for EMS-C. So she has been working with that group and thankfully with our larger group for the last few years.
Yeah, and I was certainly aware of that, obviously, having been on that subgroup a little bit. But then, again, the consistency with what is done nationally, I think, will be very, very important, that we don't go ahead and, in a little corner of New York State, develop our own things, when really we should be looking at the national objectives. And I just wanted to make sure that that's just stated.
Thank you all. So we'll look forward to getting more on this at our next meeting. Hopefully we'll maybe even have a first draft of a script by that time, I'm hoping. I know that's a tall order in the next couple of months, but I know we have a lot of people here who are really devoted and dedicated, and I have confidence that we can get something together in that period of time. Okay, now we have the opportunity to hear in rapid fire 3 quick reports from Amy Eisenhower. Unfortunately, Megan Williams, who had assumed responsibility for the length-based resuscitation tape issue and the interface with the collaborative protocols, was unable to make it today. We found that out at the last minute. Perhaps Amy could just say a very brief word about what Megan shared with her in terms of progress to date. But Amy is going to share with us all the rest of the old business, and before we move on to Ed Conway and a discussion of the ACLS PAL standards. Thank you.
Thank you, Dr. Cooper. So the first topic is the Always Ready for Children Pediatric Recognition Program for emergency departments and the PEC program that is rolled into that. It's the PECs within the program kind of making sure that things are ready. So I did present on this last meeting in May. This has been through EDCC, hospitals looked over it. This committee looked over it, STAC looked over it, and I believe CMEC and SUMSCO were aware, although it was really our group and STAC that acknowledged it and supported it moving forward. So since then, much thanks to Public Affairs Group, they put together, well, they really edited our main page and then added this one in. So any hospitals can go to this page to learn more about our Always Ready for Children program. And I had got some questions about this, which is why I wanted to just kind of review and then also state that it's open, so please apply. So there are 3 levels of recognition. Pediatric engaged, so the National Pediatric Readiness Project is the survey that I believe comes out every 4 to 5 years, and it's supported by our grant sponsor, HRSA, from our EMS-C data center, and then our state supports it by informing you that it's available and me offering any support with any questions you might have. So I believe the next one comes up in the next 2 or 3 years. So that National Pediatric Readiness Project also has a interim survey, so you can look at pedsready.org and look at that survey, find your hospital in there. You can complete the survey for yourself just to see where you're at currently, and it will issue a gap report. And then you can use that within your hospital to see how you're doing, how you can improve, what things you're doing great, all of that. And of course, if you have any questions about any of that, please email me or reach out to me, and I'm happy to help you or direct you. Pediatric Engaged would participate in the NPRP or NPRA. They would report their readiness score, and any score is eligible, so it doesn't matter where you are on your readiness spectrum or adventure, please join us. And then identify a pediatric emergency care coordinator. We would prefer that you have at least 1 nurse and 1 physician because there are a variety of providers working in the hospital environment, and they each have different education backgrounds and measures and requirements. So EMS-C Federal has found that it's best to have everybody involved on your team. That doesn't mean that you can only have physicians and nurses. I know Ben here is one of our injury prevention folks, and I know many of the trauma registrars and injury prevention professionals in the emergency departments are already doing much of this work. So if you have more than nurses and physicians that want to join, please add them as well. Then Pediatric Ready, again, NPRP, NPRA. Your score will be 70 or above in that readiness assessment or gap report that you receive back. And of course, you're going to identify your PECs in your ED. Pediatric Innovators would complete the survey, would score 80 or above in their readiness. They're going to identify pediatric emergency care coordinators, and then they're going to share some of their best practices. And so best practices doesn't always involve what went great for us. Sometimes it could be, we tried this thing and it didn't go great. Any of your best practices and resources in the future, and I'm talking like 3 years down the road once more hospitals are involved and invested, I would love to have some mentoring And I know that there are many larger systems that the specialty hospitals reach out to the other hospitals in their systems and kind of perform that. So in the future, I would love to include that as well. In here, some more information, and you can reach out to me or Jacob until the 15th and submit your information to our form, and that comes right back to me. It doesn't go anywhere else. That would be your commitment letter, and then your gap report. And then, of course, if you have any questions, want any resources, want any suggestions, I'm always here to be a resource, and my email is all over our website. Does anybody have any questions about the program?
Amy, I have a question. This is a great,
Sure.
great step forward. I absolutely think so. My question to you has to do with what is in it for the hospitals? You know, is there some public, is there a sticker, is there a decal, is there a sort of a proverbial good housekeeping seal that, you know, an emergency department has this recognition by the state? How is that going to be rolled out? Because that, if it's a matter of, okay, you have to apply, you're in this, you have some, whatever the level of recognition is, but no one knows it in your region, I just wonder what's in it, why would they do it? Except for the goodness of their heart, because everybody wants to take care of kids really well. But I just wonder if some thought has been given to the actual, it's not marketing perhaps, but certainly awareness in the public that a particular emergency department has these qualifications.
That is an excellent question. So part of the development behind this in New York State and certainly nationally, one part is that this is one of the EMS for Children performance measures for the new grant period. So this will be assessed in the National Pediatric Readiness Assessment, self-reported by hospitals, but it'll be assessed there. Also, I've been working with Public Affairs Group to develop recognition certificates and other items for hospitals to display in their ER or other places to recognize that they're part of our program and are committed to pediatric readiness. And then also, I know nationally there has been some attention kind of flowing through the EMS-C Innovation Center around pediatric readiness, hospitals that are involved, and that is certainly not from us, but I know that there is a national look at this right now. This is also structured to be the Pediatric Emergency Care Coordinator portion for American College of Surgeons trauma designation. And so that was really, we wanted to make sure that this was ready because I know that, and maybe Patty can say, is that book now in effect? September 30th? So September 30th, you will be required to have a pediatric emergency care coordinator for your ACS verification, and I believe re-verification, Patty? So this program is designated for that. I know some hospitals have reached out to me asking about the pediatric readiness assessment, other things that they might need. So I know some of our hospitals are already on it, collecting their documents and putting them together. Did I answer your question?
Yeah, I think so to a large degree, but I still wonder about the recognition of a hospital in the public eye, whether that should be considered. And how that would be done. I am aware of the trauma issue, and in fact, the reason I'm following up on some of these, or looking into this a little bit, is because our trauma surgeon at our level 1 pediatric trauma center basically asked me, well, do you know who the PECs are for the hospitals that are within our system? And that's where that prompted an email to Amy saying, how do I find this out? And then I find out a bit about this program. But then it became clear that it isn't so clear who these PECs are and how do you get it. But of course, it was all had to do with the verification and re-verification for the trauma systems. But it pointed out, again, going back to this program, that there's maybe not a lot of knowledge out there, you know, on the hospital side of things.
Yes.
Because you would have thought that people who are running a trauma system with 5 hospitals at the minimum, that they would know something about this, and it just didn't seem to be there. So I'm very into the recognition,
Yes.
and both publicly and within hospitals, including discussion. Is there been discussion with HANES, the Hospital Association? I mean, how does this all work? I'm not quite sure.
So this program was rolled out at the end of June. Since then, there have been presentations at STAC. So there is awareness at the STAC level, and this committee and STAC, particularly Dr. Wallenstein and the Pediatric STAC Subcommittee, have been involved in guidance to developing this program. Now, most of it was already done because EIIC, there's been much research behind this. Other states have put together similar programs. So a lot of the work had been done by predecessors, and we put it together in a New York State format. However, the State Trauma Advisory Committee has been involved in this work. I've also been going out to regional trauma advisory committee meetings and sharing information with them. Obviously, this was rolled out officially in June, and the summer came. So I have been to Syracuse, I've been to New York City, virtually, I've been to the Capital Region meeting, and I'm waiting for the other meetings to come up to present to them as well. But I do agree that public recognition in the local communities would be an excellent provision related to this program. Dr. Harris.
Yeah, thanks. I think one of the interesting challenges is that the PEDS Ready program at the national level is meant to be iterative, right? You do a self-assessment, your score is not publicly available, and you see the facets, the different buckets where you need improvement, and then there is an abundance of opportunity just from the EIC website and here as well of how you can improve. I know that locally in Long Island, there have been some hospitals that have done this and then said, hey, we hit that 70% mark, which has a 3 times reduction in mortality compared to other hospitals. But it's also, because it's iterative, you do run the risk of hospitals that say, hey, we are a 75, then they have a change of leadership and a third of their nursing staff leaves, their PEC leaves, and now, it's sort of like the U.S. News and World Report. What happens today isn't necessarily valid tomorrow. But I do think that you're right, it is a nice, we should consider some opportunity for the recognition that comes with just the effort of participating, because I think nationally, and is a hot topic I think I'd love to discuss with Chief Pataki later, but the number of hospitals that participate voluntarily is relatively low.
I think just going beyond like the public recognition, because obviously everybody wants that, but we do something like a little bit less formal because we have a decent catchment area, and the general public kind of thinks that, or at least in our region, that a hospital is a hospital, and they think that the services are pretty uniform across all platforms. And unless you're actually involved in healthcare, that's how a lot of people think. What we do as being the only pediatric center is we go to all the adult sites, and I know it's probably a little bit different downstate, but we even go to like competing hospital groups because we're the only ped center, and they primarily deal with adults, and we do a pediatric readiness, mostly in the ED. We examine their Braslow card. We examine how well they can basically handle the patient throughput and do the initial like high acuity care and the path flow to get them to definitive care. And they really appreciate it from a staff standpoint, because I don't know, there's a lot of healthcare professionals that are out there that don't generally deal with high acuity peds, and especially if they work in an adult site primarily, and then they have a bad incident and talk about mental health right there. So it's not only doing it for the public awareness, but it's doing it so your clinical staff feels comfortable and is familiar with the equipment that they have, where their deficits lie, and then you can work on that through multiple like iterations in order to make it so you have like a more robust program. So I think that, even though we want outward facing things to look great, sometimes we have to look at, the retention within, and that deals with the mental health with our clinical providers and staff.
I think that's a great point, especially mentioning adults only sites. Certainly, they take children if pediatric patients come in, but right, we have pediatric specialty centers for those critical patients. However, I think the thrust behind ACS making this a requirement is that the same thing happens at adult trauma centers. So you're adult verified, and they check those things, but pediatric verified is another separate assessment. And obviously, I think the general public is not necessarily always aware, but this was really adopted by ACS to approach that so that everybody is prepared no matter where the patient ends up.
Yeah, well, the nice thing about trauma centers is trauma centers often are the ones that drive a lot of initiatives because of the regulations, which is a great thing to make certain hospital groups push forward in directions maybe that they wouldn't normally think to do.
Thank you. So the next report, pediatric triage guidelines. So there is a subgroup comprised of members from EMS for Children, members from STAC, and members from CMAC and SEMSCO that have been meeting regularly to develop some education around the 2021 trauma triage guidelines that came out with some adjustments. So just recently, as of Friday, which is why we don't have information for this meeting, we will definitely have that for next meeting. And I know that there will be some information coming out at STAC about that, and all of that just went down this afternoon. So they did come up with a standardized statewide template with room for regional specifics. A lot of the conversation in that work group was there is a difference between trauma in New York City and trauma in the North Country or other areas of the state, and how long does it take to get to your trauma center, and what does that look like? So there is room there for some regional specifics, but there is standardization on the education across the state, and I believe the next meeting that specifics about that will be STAC, which again is October 11th, but I will ask Doug Sandbrook and Mark Devers, who kind of spearheaded that effort, to come to our next meeting with specifics about that education. And I know it's been a topic that was important here, but also at STAC and CMAC and SEMSCO. And then pediatric stroke. So I believe last meeting, Dr. Winslow from Suffolk joined us, and he brought up a question related to our collaborative protocols in where to take pediatric stroke patients. And stroke designation had some questions because they said, well, where do you guys take stroke patients? So there has been much conversation in designation at Coverdell, which is the other part of my job. So the Coverdell Stroke Program, I'm their EMS liaison. At EMS-C here, so kind of to cover what's been happening, designation wants it to be very clear that they do not cover, or they do not designate pediatric stroke centers. And that was also a big part of the conversation. So there are no New York State pediatric stroke centers. We did discuss with Dr. Cushman, because in the collaborative protocols, that's not very clear. They are going to put forth some suggestions in the next CMAC SEMSCO Med Standards meetings next week, also held here, to amend that collaborative protocol to add, for pediatric stroke patients, please call online medical control for transport decision. So that depending on where you are in the state, what's available. And I will say that designation made some excellent maps. And we're a little short on time now, but those are inboardable, but made some excellent maps with overlay of where specific stroke centers are and where pediatric centers are. And in some places, there is great overlap, and in other places, there is not. So that question is ongoing. They are working with their advisory board, so there's a stroke advisory board, much like this group, where they talk about what the best practices are and what recommendations are, and they're working with their advisory board, and many of us know Dr. Daly from Albany Med. He is a member of that group, so EMS is also represented there, and they've been kind enough to include myself and Crystal from Coverdell to those meetings. So those are being explored. And then we have an education subgroup. Dr. Daly has agreed to join us with many of the members here. And we had our first meeting a few weeks ago, and currently we are getting data from both hospitals. So designation is procuring some of that hospital data, discharge data for us. And Jacob is working on a report of EMS data around stroke patients and where they've been transported or where they haven't been, et cetera. So we will have more on that at the next meeting with specifics on what best practices are from both us and Designations Advisory Committee. And I think that's all of my information here, unless anybody has any questions.
No question, but did Megan Williams share anything with you about her work?
Yes, so the length-based measuring tape and kind of, I don't want to say coordination, but comparison with the pediatric protocols, she did say that they went through all of it. Her paramedic students that have been doing the comparison as part of their course, they had gone through all of it, that she does have some documents that they drafted. She sent me the report after our EDCC, so she was going to come here and discuss it, but I will find out what those documents are and get them available for us at our next meeting.
Would it be helpful to share them before the next meeting, or do we have to get EDCC approval even to share them before the next meeting?
We are supposed to get EDCC approval to share them even on Boardable, as far as I understand. We can have a work group? Okay.
So let's do that. Let's just make sure that those get out so that there's a group of us here that have had an opportunity to look them over and you know, so we're in a position to take whatever action needs to be taken next time. Good. Ed Conway, you're up.
So thank you. So I guess I have a dog in the fight here, but so just to go back to the group, 6-7 years ago, there was a heated discussion. The adult emergency world felt that they didn't have to take ACLS in some of the courses. So one of the recommendations was, and now I wear a different hat as a chair and as a chief of critical care, so it came up about PALS. And there was a resurgence of it recently, and Art already alluded to Marianne Gauch, and who I understand, I think, is ultimately retired from her position in EMS-C in California. However, for their last meeting, a friend of a friend reached out and said, I know you guys had this conversation in New York. It's being raised, I guess, across the country. Do physicians that practice resuscitation daily need PALS? Now, I get asked this all the time. I sit on the credentials committee at my hospital. So I'm just opening it up again. Our former commissioner, who was a peds critical care doc and anesthesiologist, felt strongly that PALS should be required. Most of us probably on our credentialing have to check that we've successfully taken a PALS course. When the 405s regulations came out, 6-8 years ago, streamlining exactly what's needed for a PICU, PALS was required. So just opening it up just to see if the feelings have changed and if you're, perhaps at your institution, you're getting an upstroke. Because at our institution, it went from the emergency docs to the critical care docs, anesthesia sort of filtering out, now peds cardiology. So again, I'm okay with the recommendation as is, but I was just curious to see, since other states and other places have brought this up, what people, I mean, time is getting more and more limited, for all these mandated courses, or as we call it, the unfunded mandates, so.
Well, Ed, I'm going to jump in on this since I've been fighting this battle for 30 or 35 years. It comes up actually far more often with respect to ATLS than it does with respect to PALS, although I would argue that the PALS issue is probably the more pressing one because most individuals do have some experience with adult trauma resuscitation, whereas not everyone has experience with pediatric resuscitation. At least in New York State, okay, the department has made a decision that it's going to abide by College of Surgeons standards. Now, the College of Surgeons standards, as I recall, do state that if you are a board-certified emergency medicine physician who's regularly treating trauma patients, that's one thing. we as surgeons continue to require it for our surgeons who arguably treat, trauma with some degree of regularity. But we insist on their being current in HLS, if for no other reason than that the standards change every few years, right? And making sure that you're up to date with the latest and greatest in terms of, trauma resuscitation. That's very important to us as surgeons. I think to take two large steps backward and look at the big picture here, the real issue is, are you really frequently engaged in, resuscitation, be it trauma, be it pediatrics, be it both, or neither, right? And that's really the issue. It's not as simple as saying that, every surgeon, who never sees a trauma patient, I wouldn't expect that, for example, a breast surgeon or a bariatric surgeon who's never taking trauma call necessarily to, be, forced to take ATLS if they never, ever actually take care of a trauma patient. On the other hand, if they are part of a trauma panel, to take call occasionally, intermittently, and are not taking care of trauma patients every day, absolutely they should be, current in ATLS. But folks who are actually, the core group in the trauma panel, who are, say, as an example, board certified trauma critical care people, I think a reasonable argument can be made that that they don't need to do that. Now, let's transfer that same kind of thought process to pediatrics. Okay, I think if you're a pediatric emergency medicine physician, if you're a pediatric critical care physician who's regularly taking care of, critically ill patients, whether in the ED or whether in the ICU, and you're doing resuscitations reasonably frequency, an argument can be made that, you're teaching it, rather than just doing it intermittently. But, for anyone else who's not doing it on a regular basis, I think it's reasonable to expect that people will be current. And since there's no real good way, of saying or learning, who actually is conducting resuscitations on a frequent basis and who isn't, I think for me personally, there's no easy way other than asking people to, continue to maintain their currency, in terms of pediatric advanced life support. I'll also say that the opportunities to stay current with pediatric resuscitation are far more numerous than they were in years past. There are all kinds of, online courses that can be taken and so on. Not that online courses are the be-all and end-all. We all know that. We all know that that the ability to use a pediatric bag and mask for a pediatric patient is probably the core skill for anybody, who's going to be resuscitating a child. Not that there aren't other skills that are, also incredibly important, but, in terms of the immediate, save the life of the child, being able to successfully, maintain an airway and reestablish effective ventilation and oxygenation, really critical. So for me personally, I've always come down and saying that, that I think it should continue to be required. I may be in a minority in the larger community, but surgeons and, and so on, and certainly in emergency medicine, but this is something about which I feel pretty strongly. Anybody else?
Yes, Dr. Cooper and Dr. Connor, I just turned back to Part 405, okay, because I remember these discussions that we had many years ago now. And in that, it does not specifically say that it must be specifically PALS or ATLS. It says, or a program that is equivalent to it. I just want to make sure that that's really clear. And the example that was given at that time was the American Academy of Pediatrics APPLS course, the APLS course, as compared to PALS. So if you had APPLS, it was okay. And PFCC would be another one. There would be other courses as well, just to be very clear that it doesn't have to be. But the idea, I think, is that someone who is in the position of having to do a resuscitation must have training in that particular skill. And I think how it is done is a little bit different. And I can give you an example from our institution. We have gone to RQI, which is, Resuscitation Quality Improvement Program of the AHA, in lieu of PALS. Now, PALS you can do as well, but that is the in lieu of. And so I think there are some different ways of satisfying the criteria that are put forth in Part 405. But it's there still. You still have to have the experience. So.
Is there anyone who disagrees with the fundamental notion that, that you need to have appropriate training in current, training in pediatric resuscitation?
Just to make it clear, I think strongly that we should have it. It's just that it was brought up, and I thought I would just toss it out there again and see.
Important that you did. Thank you. Director Greenberg.
Is there anything that you're asking from that, or just a discussion amongst this group, or?
No, just a discussion amongst the group. And I'm sure that people locally must have these discussions. Or maybe it's just the crazy people down in New York, which is why we have to have a separate video.
And
Absolutely.
Upstate is just as crazy as downstate sometimes. So.
Different ways.
I do think what we are hearing, Ryan, is the sense of the group that we are, as a group, if you will, re-endorsing our previous position. And I do believe that the minutes should clearly reflect that, that we agree that if you're going to be conducting pediatric resuscitation, you need to have appropriate training in pediatric resuscitation, and that the standards as they exist, i.e. PALS or the equivalent thereof, is appropriate language that meets that requirement. So I'm going to, because this is an important issue for the record, I'm going to ask someone to make a motion to that effect, that we are re-endorsing our previous position that
So before you make that motion.
Yes,
well,
sure.
Actually, go ahead and make the motion, then we'll have discussion.
well, I can't make the motion.
I'll
but-
make a motion that
Thank
we
you, Kevin.
endorse our previous.
And what's the actual language for the motion, please?
I think he wants me to supply the language.
You can make a motion for anything. We're going to have a discussion, and you can modify your motion based on that.
I'll make a motion that we endorse our previous guidelines or statement.
That support.
Oh, that support everyone being current with their PALS and,
Or the equivalent. Right.
or the equivalent.
Can I make a friendly addendum to that motion?
I think at this point, it would be open for discussion first, and then you would make an addendum.
We actually need a second first.
Oh, yeah.
Second.
Thank you, okay.
Now I think you'd be
Dr.
open
Conway,
for
second.
discussion.
So let's have discussion. Ed, please.
So just the addendum would be to include the word recertification as well. The initial certification and continued recertification.
Kevin, you accept that friendly amendment?
I do.
In the past, as you speak about here, how did you share this information, or what was it that you put out that showed your position?
It was in the minutes of the meetings, those many years ago. I think that actually predated your time with us.
Well, it was actually included in Part 405.
That is also true.
That's where it was, that we had our discussion, and then it was actually included in that in terms of training and maintaining PALS and ATLS training.
Was that in the 405s just related to trauma centers, or was that in the 405s related to something else?
It is right here. It's in Title 10, Part 405.19 D1IA. Requires, and I'll read it, Emergency services attending physician shall be a licensed and currently registered physician who is currently certified on advanced trauma life support or has current training and experience equivalent to ATLS. Such physician shall also have successfully completed a course and be current in advanced cardiac life support and pediatric life support, or have had current training and experience equivalent to ACLS and PALS. If I bear with me, I'll just read 2 more sentences here. Those emergency attending physicians who are currently board certified in emergency medicine will be considered as having current training and experience to ATLS and ACLS. They will not be considered to have current training and experience equivalent to PALS. Those emergency attending physicians who are currently not board certified in emergency medicine will continue to be required to be current in ATLS, ACLS, and PALS, or other structured educational programs that are deemed equivalent by the department, and then it references as the APLS and PALS. So that is the specific training, and that includes then that they are to be current in it, which implies recertification, but it doesn't have to be the specific courses, but they do have to have equivalent training as determined by the department, it says.
Dr. Van Duyak, can you read out Part 405 dot?
Yes, it's 405.19, and then parenthesis D, parenthesis 1, parenthesis I, parenthesis A.
Okay.
And that is the section.
Parenthesis I.
Yes.
And
And
then
then parenthesis A.
Oh, my goodness.
And
Correct.
this was the culmination of many, many meetings of discussion to set standards for pediatrics resuscitation.
My thought is that this is interpreted very differently, institution to institution. So it's our recommendation, but all the institutions that I've been in, in New York, have interpreted it differently.
So you bring up an interesting point then, because in the world of regulation, we have statute. Statute comes down to regulation, and then regulation is further defined in policy. We don't enforce against policy, we clarify in policy, we enforce against regulation and statute. And so is this a situation to where there's an opportunity to maybe make a recommendation to, really it would be the hospital division or FIPIC, or well, the hospital division, I think my counterpart on that side, to offer a guidance document or further clarification or a policy statement or a dear administrator letter, which are the ways that we communicate out on, how best this should be standardized or followed throughout the state so that there's not as much. There will always be some differentiation from facility to facility, but maybe there can be less of a variation from one to the other.
If I could, again, read from this document here. What I wrote to you, the first paragraph that I wrote was the policy entitled in Part 405. The second paragraph is a guidance on how that is to be interpreted. This comes from a letter that was sent to all the CEOs of all the hospitals in the New York State. So it included policy, and like you said, included then what does that really mean? And that's where they did that. If we want to change that, that is certainly an option, but that is what was sent out.
So that's a Dear Administrator letter, then, as you can see, my never-ending spiral. It's not coming up on my computer yet. So that is a Dear Administrator letter, and so I think if anything, if you were to look at this and maybe share information or your recommendation would be to further support that you reviewed and support the Dear Administrator letter dated blah, 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 and maybe even a recommendation letter for that letter to be sent out again. When was that sent out? Not like last week, was it?
May 8, 2018.
Okay, so 5 years ago.
Elise, would you share that with everyone or share it with Amy so it can be shared with everyone?
I'll share it. Glad to share it with Amy.
I think that just might give an action to what you're looking for.
Kevin, do you accept that?
I do, thank you.
Ed, you're okay as a seconder?
Yes.
Can somebody clarify the language so that I can document it?
Dr. Cooper, can you clarify the language that you would like Ed to second?
I think the language that Kevin Albert proposed and Ed Conway supported as the seconder was to endorse or re-endorse and support the administrator letter of May, whatever the date was, 2018, regarding the necessity for pediatric resuscitation training in emergency departments in New York State. That work, guys? The director says there's the person next to him.
She's the one that has to type as fast as you were thinking.
That's not difficult.
Okay, is what's on the screen acceptable to everybody?
Sure, that's fine. Everybody okay with what's on the screen?
Dr. Albert would have to accept those
Yes,
modifications. to
that
his-
is fine.
Ed?
Yes, I agree.
Okay. Further discussion? All in favor? Please signify by saying aye. Raising your hand.
Aye.
Any opposed? Okay, carries without dissent. Thank you. Unanimous. All right. Thank you. Ed, thanks for bringing that issue to us yet again. So it's now time for our updates from our sister committees. Just very quickly, however, Elise, I think you're still involved on some level with the PALS process in terms of potential updates. You know, it's 2003 already, and almost 2004, as, you know, the time goes by. Has there been any forward movement as of this time in terms of developing the next round of standards and guidelines for pediatric advanced life support via the Heart Association?
Well, as you know, I think the formatting or the planning of these guidelines it's not every 5 years, it's a continuous process. So every 1 to 2 years, they put forth answers to some new research and questions about recommendations. And so I'm not aware that there is anything major new unless others have here looked at that, but it's not an every 5-year process. Basically, it's an ongoing process of updates, and to my knowledge, there is no brand new update that would be relevant at this point to this committee.
Okay, thank you. Okay, so let's move into our updates from DOH partners and sister advisory committees. We'll begin with PCARN. Unfortunately, Dr. Brooke Lerner and Dr. Peter Dion are not available to be with us today, but Amy does have a brief report from Dr. Lerner.
Thank you, Dr. Cooper. Dr. Lerner was unable to travel, but she did give me some updates. I know that in August, they were waiting for their updated funding. They are also funded by HRSA as part of the umbrella of EMS for Children programs nationally. I believe they have been refunded because I've talked to them since. They shared with me that in their TREX study, which is their asthma study that they shared with us, I'm not sure if it was last meeting or the meeting before that, they are in the process of community consultation surrounding that study. So in the communities across the country where they are going to be rolling out this study, they're letting the community know. And then the PD dose study, which is active here in New York State in the Buffalo area. I believe AMR Buffalo is participating. And that's the seizure treatment study. It's ongoing, and they've had 30 enrolled in Buffalo and 900 across the nation. I believe 20 states, including us, are participating in that program. And if you have any questions, please forward them to me, and I'll share them with Dr. Lerner and Dr. Diane.
let's just be sure that our minutes reflect our gratitude for her report, and that we all send her our best wishes. Thank you. Okay, Christine Akey and Chris Alfonso from BOHIP.
Hi, I'm Christina Akey. I'm a health educator at the Bureau of Occupational Health and Injury Prevention. I'm going to cover part of our update of what we've been doing. The first one being pedestrian safety. Closer? Okay, much better. 4'11", you know. Okay, the CNBC campaign that you may see with our public service announcements on TV. We did add our intersections bookmark. We have a K-5 pedestrian safety for children Walking with Daisy video that is on our website. We complemented that with a coloring book that is on our website, and we have 10-second vignettes that is also available on our website and through all of the social media platforms at DOH. We have a failure to yield PSA that was produced and a publication to go along with that. Our pedestrian safety campaign media buy that is ongoing, and all of what we do in pedestrian safety for any age is to raise awareness and reduce pedestrian-related injuries and fatalities through education and working with the vehicle and traffic law. Next, I'll move on to our child passenger safety program. We have conducted 2 SurveyMonkey questionnaires, one that went out to law enforcement and basically asking them if they're utilizing our materials. The other one was a needs assessment for family service providers across New York State. We had 67 responses from law enforcement and 72 from family service providers. So we will take all of our information, and it included questions as far as languages and translations and things that are needed in all of our communities in New York State. We also are in the process, we created a draft script for a CPS pictorial video to illustrate how to install car seats, and that is very low verbiage on the video, and it is a hands-on video for our low literacy as well as our non-English speaking residents of New York State. So we have the script ready. We will go into production next year. Younger driver safety. We are working currently on a publication using the shared risk and protective factors, and this is going to be for parents and caregivers. That should be completed, also being approved as we speak by September 30th. Also, if you're not familiar, we do have what is called DEREC. It is our Driver Education Research and Innovation Center. It is a standardized curriculum that we are trying to promote across New York State. We just had a couple of driver ed instructors do a pilot program in Broome County for our driver's ed instructors. We want to standardize the learning instead of using the 1986 textbooks. And pretty much we will have 4 more pilots in the next grant cycle.
Hi folks, I'm Chris Alfonso. I'm also a member of BOHIP. I'm a senior health program coordinator. Some other section areas that we've been doing some work on. We just completed a PSA for motorcycle safety with our new tagline of Ride, Drive, Care, promoting collaboration in safety between motorcycle riders and car drivers. We also have just created a publication that's going to educate motorcycle riders on how to receive their permit and license, as well as educating them on the benefits of taking a basic safety course, basic rider course. Recently, we just sent out another survey, our ACEs Prevention through Home Visiting Services publication. This survey was the second of 2 surveys to examine how to increase the utilization of home visiting program referrals from domestic violence shelters. Home visiting was also referred to as family support programs for pregnant and parenting families. And it's shown to decrease adverse childhood experiences. So we received 47 responses. And the next steps will be presented at the Safe States Alliance Annual Conference in Denver, Colorado, and that's in September of this year. Next week, actually. And then we have a presentation titled Racial Disparities Among Injuries Complicating Pregnancy in New York State from years 2016, 2020. And it's going to be presented at the Safe States Alliance Annual Conference also in Denver, Colorado next week. And the presentation is going to focus on the statistical summaries and analysis around injuries complicating pregnancies in New York State.
One last thing I'd like to add, all of our materials are free of charge. They are located on our website under the Injury Prevention in New York State. To the left, you will see a catalog, and then you open up the catalog and there's an order form. Thank you.
Thank you so much. Any questions for our colleagues from BOHIP? Sir. Ben.
You just have an open mic. Just one question. I know that a lot of people down in New York City, but then also a lot of like the more urban areas throughout New York State are having a pretty significant issue with the electric bikes and scooters, and there's just not a lot of classification. A lot of young kids think that they're fairly, or they're not as dangerous as our trauma centers have indicated that they are. I just didn't know if there's any plans to have some type of education revolving around that topic.
Absolutely. I think there are some talks with some of our colleagues in New York City in trying to, first of all, classify some of these devices, which then will help us on the enforcement side of things. I know that there is a lot of education around, in particularly charging these devices. We know that the lithium-ion batteries can be dangerous in some cases, cause fires. There's not a lot of knowledge or education around that right now, and so that is the primary focus as of right now.
Thank you.
If I can chime in on that one, at our institution, we've seen just over the last several months 4 fatal fires as a result of these electric bikes. Chief Pataki knows what I'm talking about. What happens is folks bring these bikes indoors. They put the bikes right by the front door of the apartment. Plug the battery in to charge. It overheats, starts the fire, and then blocks the exit to the apartment, and people can't get out. And these are devastating injuries. We've had people, jump out windows to try to get away from the fire, and all the attendant trauma associated therewith, and so on. It's, I would have to tell you that probably more than half of the trauma activations that I see in my Center for Kids involves or involve either, bikes that have electric motors attached to them, scooters, mopeds, they're everywhere. Cars hitting them hitting cars, et cetera, et cetera. And often multiple people riding on the same, electrified vehicle. So it's those injuries, fortunately, are mostly minor head injuries, and a lot of orthopedic injuries. But we have had some really major injuries as well. Bilateral pneumothoraces, severe renal lacerations, liver lacerations, so on. I mean, these are dangerous items, and I think as Ben Casper has pointed out, we need some more robust education on this. This is, a request that I'm going to personally make on behalf of the committee that BOHIP really address this and really move it to the very high up on the agenda. It's a big problem.
Just really quickly to address Ben's question about that work in New York City. I happened to be at the RTAC meeting for the ARC program, and their Department of Health, so New York City Department of Health, came and wanted to work with those hospitals on, and the registrars specifically, related to what kind of diagnoses they're having, what ICD-10 codes they're using, so that they could try to map out how they could look at data, because their initial thought was, okay, we'll use police reports, but not everybody is filing a police report. Some people self-report to the hospitals. So if you had more, and I know that work is ongoing, but if you had more questions, I could connect you with people that might have more information about that, and same for you.
Yeah, absolutely. I think right now there's going to be a lot of focus on getting the general public educated on just general safety protocols for using these devices, let alone children using them. I think there's a steep learning curve. There's also a lot of differences between safety in different devices depending on the manufacturer. There's not a lot of standardization in that realm right now either, and so some devices are safer than others to utilize, to charge, so there's some work being done on that as well.
Also to note that collaboration with the Governor's Traffic Safety Committee is ongoing, and Chris is the lead for the micromobility portion.
Micromobility, that's the term of art. Okay, well, now we know. Thank you. Other comments or questions? Hearing none, let's move to Marilyn Kasika. Marilyn, it's so good to see you again. Thank you for coming.
Sure. To those of you who don't know me, I'm Dr. Marilyn Kasika. I am the medical director in the Division of Family Health. I'm a pediatrician with subspecialties in infectious disease and preventive medicine. And I love hearing your conversation. So I just wanted to highlight to the group that we put out a report on infant mortality in New York State, and it was for the years 2016 to 2019. And I want to point out that overall, New York State is the 4th best in the nation as far as infant mortality. We have the 4th lowest rate. So I think, that is a positive. And from 2016 to 2019, we also had a decrease in infant mortality of 12%. So our current rate in 2019 was 3.85 per 1,000 infant deaths, per 1,000 infants. When we look at disparity, however, we see that non-Hispanic Black infants are dying at a rate of 2.8 times that of non-Hispanic white infants. And during that time period, all races improved or decreased infant mortality except for non-Hispanic Blacks. We also did some looks at geography, and we looked at upstate versus downstate. And downstate, we included Mid-Hudson, New York City, and Long Island. And upstate had much higher rates than downstate as far as infant mortality. When we looked at it, upstate was 5.6 versus downstate at 3.44. And within all the regions, the Finger Lakes did the worst. And even with better rates across the state, disparity existed no matter where you looked. It just depended on the severity of it. So I think it was interesting, and I think there's a lot of work to be done, especially at the regional level, because I think people understand what's happening in their area. There were recommendations that the committee put forth, and I think it's things that we'll be working on coming up.
Thank you. Director Ryan?
Thank you. When you talk about upstate versus downstate, was there anything that you were able to target or look at or see on why you think that occurred? And even furthermore, maybe even why Finger Lakes would have a higher mortality than other areas?
Not from the data that we looked at. I think that we were surprised because in the Finger Lakes, we've seen a lot of, very proactive work going on. But I think that's why we have to look at it regionally to understand the differences. What is missing? What are the gaps that one region has that the other doesn't, that, we can share?
I'm in the Finger Lakes area, so this obviously is an important point. So going again a little bit with what Mr. Greenberg said, was there an ability to look at counties that were involved? So, for example, we often break down it in the metropolitan sort of Rochester area city, which is Monroe County, versus rural counties, which are immediately to the south, east, and west of that. So I'm wondering if there is a relationship there.
We didn't go into that detail. I think this was the first overall,
cut.
Statewide report and then looking at it regionally. But I think as we all know, the more you look at it, the more questions you have.
Sure.
And that's the kind of detail that needs to be done next.
One of the additions to that is, as many of you probably know, is the city of Rochester has one of the highest poverty levels for children in the country. And I wonder, as you are looking at mortality, I'm sure that some of those demographics might be available in the data set. So to look at the demographics of that in knowing at least that there is such a high degree of poverty in the city, which outstrips almost any city in the country per capita, is really an important bit of information, I think.
Yeah, just to follow up on that, being an EMS provider from the Finger Lakes region, one of the often forgotten demographics that saturates the Finger Lakes region more than any other region would be the Amish and Mennonite populations, and they do not deliver in the hospital. They deliver at home, and they only call us when it's really, really bad. So that could lead to a little bit of it as well. And I think as we, as that data gets dove into a little bit more, that may be something that actually comes out of it is this population that's often forgotten about because we don't interact with them regularly. That's where a good portion of some of the worst pediatric calls I've been on personally are due to those populations, whether it be births gone bad or 3-year-olds working on a farm. So
I think the ethnicity, like you said, or the background is really important. But the other aspect of it I would encourage you to look at is when during that first year of life these mortalities occur. Because if they occur within the first 2 weeks and they're in the NICU, we're a major referral center, that's something to be taken into consideration versus, the high mortality rate is particularly in the 1 month to 1 year. That's a very different, so again, that's available, I'm sure, at some second and third cuts.
That breakdown is in the report, neonatal versus post-neonatal. So all that's there, and for each geographic region. And we looked at it by the county of the mom. So,
Marilyn, would you be kind enough to share a link to that report with Amy so we can get it out to the group? Thank you so much. Any other questions?
I think Amy did share it.
It's in Boardable. Okay. Thank you. Any other questions for Dr. Kasika? Okay. Thanks for that great work as always. Thank you. Okay. Our colleagues from Health Emergency Preparedness, I think Deanna Radigan is here, right?
Hi, thank you. Yes, my name is Deanna Redigan. I'm with the Office of Health Emergency Preparedness. I'm the Healthcare Preparedness Coordinator. Just a couple quick updates that we have. The crossover activity with the National Preparedness Readiness Assessment. It's a deliverable that we have for the hospitals outside of New York City that we contract with. This is underway for this deliverable budget period, and the target for completion of that activity is June 1st of 2024. So as we get those reports, we will pass those along to Amy as an update. So we are in the process of that. And then as we get more information as it relates to the next 5-year cooperative agreement, which will be starting in July of 2024, we will flag any PEDS related activities that may be of note to this group and be sure to pass those along as well. And then just an informational, we have our Capital District Health Emergency Preparedness Coalition, our HEPIC. They are hosting their annual pediatric preparedness seminar on September 20th. So if anyone has not received that flyer and would like the information, I can pass it along to Amy.
Please share that with Amy so she can send it out. Thank you.
Absolutely.
Is that it? Okay, thank you. Any questions, sir, Ms. Radigan? Hearing none. Mike McAvoy, center stage, please.
I'll just give you a couple of things from SEMSCO and CMAC. We're meeting again next week, at which time I'll probably be assassinated based on the amount of work I made the groups do over the summer. But some very important things happened at the last. Oh, thank goodness.
I would just like to be on record as note it was Dr. McAvoy who required all the work to be done over the summer and not Director Greenberg.
Right. So some important things happened with the governor's budget. A few things that occurred at the SEMSCO and CMAC meetings. The quality metrics group completed their revision of the quality improvement guide that should be coming out as soon as we find a colorful picture to put on the cover of it. And so you'll see that shortly. There was a controversy that you may be aware of with Stop the Bleed kits in schools. The Department of Education sent a note out to school nurses that they cannot use the hemostatic dressings in those unless they have a prescription from a provider. And so we have, from SEMSCO and CMAC, written a letter to the commissioner to ask them to please confer with the state ed commissioner and fix that problem, because we had fixed it previously in 2018 and it came up again. So that's an issue that I expect to get resolved shortly. OHIP announced as of July 1 that there's a substantial increase in ambulance rates for under Medicaid. And that's been in place now in two fashions. One is they put about $30.2 million into Medicaid funding for ambulances, but more importantly, they implemented an RVU system, which will be really helpful for the future. And so now ambulance rates use the same RVU system as CMS is using in order to pay for transport. So that's helpful to our services across the state. The Rural Health Task Force is continuing to meet, and I think their report is due in December. Is that correct? So we'll get a scope of what things they've been working on with rural health then. The governor's budget had 7 things that, besides the Medicaid, that affected EMS. One of those is the budget created some laws and put some money in some things. One of the changes that got made to regs is to greatly expand the roles and responsibilities of the SEMSCO and the REMSCO. One of the tasks that has kept just about every single committee over the summer busy with is to develop performance metrics. And these are kind of reasonable and achievable benchmarks that were initially, I think, going to limit to probably 4 or 5 different items. And we have 4 committees: the Safety Committee, the Quality Metrics Committee, the Training and Education, and the Systems Committee, who each have come up with 2 proposed performance standards. And these kind of apply across the system. So they're for agencies, they're for regions, and they're for 911 centers. So we'll be vetting those and having some, I'm sure, lively discussion about which ones the SEMSCO and the CMAC want to actually adopt. There's also some money that's been put in to the Bureau's budget to do recruitment and retention, some money for funding mental health and wellness initiatives. Ryan mentioned a state task force, which could be personnel, could be ambulances, could be even specialized equipment to fill some of the gaps that occur periodically when there's crisis situations across the state. And then lastly, the volunteer EMS providers in an agency that contracts with a municipality or village, town or county are now eligible for health insurance under New York State. And so that's something that we'll get some more information on once that becomes clear through the insurance folks. But those are all big announcements and a great boon for EMS. And I think very strong recognition from the governor's office of the things that were reported in the sustainability report that we kind of leaked to them prior to their budget preparation. So a number of those things, in fact, more than half of them were actually included in the governor's budget. So good boon for EMS.
Dr. McAvoy,
Kevin, please, yes.
do you happen to know, with the issue with the hemostatic dressings in the Stop the Bleed kits, can that issue be resolved by a standing order from the medical director? Or does that have to be resolved at a higher level?
It could be resolved in that fashion. It just seemed senseless that it came out directly from state ed, so we wanted to go right to the higher level and fix it there.
Thank you.
Any other questions for Professor McAvoy? Okay, seeing none, we'll move on to the STAC and Pediatric Trauma Subcommittee. I was out of the country for our May meeting and was unable to attend, so I think Kim Wallenstein will have a nice update for us.
Very, very quick update. Unfortunately, I also was unable to attend the meeting in May because of the Pediatric Society annual meeting, where most of us were. So there was not a pediatric subcommittee meeting back in May. So not too much new to say on that front. We will be having an interim meeting of our pediatric subcommittee this Friday, and after the October meeting, there will obviously be more to talk about. We've been talking in general about our TQIP collaborative and getting topics from there to discuss, as well as having a standing initiative on the pediatric readiness initiatives that Amy Eisenhower talked about. So I'm going to be addressing some of the comments that were floated around today at the meeting that we have on Friday and then in October to see if we can add any more to that conversation. So that's all for now, but there will be more.
Thank you, Kim. Anything more for Dr. Wallenstein? Okay, well, we've come to the end of our agenda, for which I'm quite certain Director Greenberg and Amy Eisenhower will be very, very pleased. And all of you, of course. We've in the past run over by a fair amount, but now you'll actually get to go home on time. So there we are. But before we do that, Amy, will you remind us the date of the meeting? I think you said it was going to be the 4th of December. Is that right?
It will be the 4th of December, right here at the Troy Hilton Garden Inn from 1 p.m. to 4 p.m.
Thank you. And before we go, I want to just take a moment to personally thank Amy Eisenhower for the incredible volume of work that she has been doing on our behalf. Amy has more than a few balls to keep sort of spinning around, and juggling at all times, and she does it with great aplomb, and she has a memory that is like a steel trap, and she remembers all the little things that have to be done and dealt with, and so on, and deadlines, and this and that, and we're just incredibly lucky to have her, and so you can see, how readily Director Greenberg relies on her for all things pediatric. So once again, Amy, thank you on behalf of all of us. We obviously could not do it without you, and we hope you will be with us forever. So that is that. Anything anybody else has for the good of the children of New York State? Okay, well then, we will call the meeting adjourned, and we will see you in December, okay? And thank you all for coming. Safe trip home.
We can go off the record.
Motion to adjourn officially.
Motion to adjourn.
Chief Pataki, motion, second for the motion. Kevin Albert. Thank you. All in favor? Aye, 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 aye. Okay, all opposed?